welcome to the Fellows Lecture for this week. We have a special guest. Dr. Efthymios Avgerinos is a vascular surgeon and professor of surgery at the University of Pittsburgh School of Medicine. He earned his medical degree from the University of Thessaly Medical School in Greece. That's where he's currently at. So he took some time out of his busy day, his clinical work, to give the talk. He has published more than 200 peer-reviewed papers and chapters in vascular surgery, and his work is widely cited in worldwide. So he's going to speak about a review of percutaneous thrombectomy devices for ilio-femoral DVTs. I'd like everybody to welcome Dr. Avgerinos.
Well, Dr. Ngoyen, thank you so much. Dr. Papas, it's a pleasure and an honor to participate in your weekly lectures for the fellows. I have to express my admiration for your work. I've learned a lot, and I'm looking forward to a nice discussion as I will be presenting a review of my current practice on percutaneous thrombectomy for ilio-femoral DVT. As you said, Khan, I've been in the States for actually 10 years, and I've recently moved to the European side. I'm currently sharing my practice between Europe and US. I can tell you that US is far ahead right now in terms of aggressiveness in treating these patients compared to Europe. Europe is probably where US was 5 years ago in the practice for deep venous interventions. So it's actually a good opportunity for me to build up a program from scratch. I'm mainly active in the southern European area, Italy, Spain, and Greece. So I'm going to share with you the experience that I built up throughout the years in Pittsburgh. Pittsburgh is a very busy practice, and it gave me the opportunity to get involved in all these types of procedures and use all the contemporary gadgets we have available for the management of ilio-femoral DVT. And you can tell that practice is changing if you look at how many new devices we've seen throughout the past 5 years. Every single company wants to have a piece of the pie, and they're coming out with a new device and another device and another device. But at the end of the day, do they actually make the difference, or they are all the same? We'll have a look at that. These are my disclosures. So for our fellows, what are the targets of a DVT treatment? Are we doing this to prevent PE and death? Well, yes, but this is not that frequent, getting a pulmonary embolism. Or phlegmasia, again, this is not very frequent. We see prevent recurrence, maybe. But the main reasons we're doing, particularly interventional treatments for DVT, is to provide immediate symptomatic relief to our patients and to prevent, or hopefully prevent, post-thrombotic syndrome. Post-thrombotic syndrome can be debilitating, and it really affects the quality of life of these patients with skin discoloration, ulcers that are not healing, and so on. So what in your practice are you telling these patients when they present to your emergency room? A swollen leg, 2 swollen legs, painful, symptomatic, they're not getting better with blood thinners. Are you just telling them, just keep up with your blood thinners, use compression, and you'll be fine? Well, I don't think this is an acceptable answers in the 21st century. Selected patients can benefit from catheter interventions. And I understand the evidence is still controversial. It's still an unresolved clinical controversy. But as Dr. Bedenham, the principal investigator of the trial, recently wrote, catheter-directed thrombolysis can actually be beneficial, provided that you're using it wisely. And in the very recent guidelines, the European guidelines, the EFVS guidelines, actually recommend early thrombus removal strategies for symptomatic ilio-femoral deep vein thrombosis, but in selected patients. And let's see how we select these patients. Well, a few years ago, I wrote this editorial because I really believe that catheter-directed thrombolysis is attractive. It is attractive like these nice, attractive Hollywood actors because of the open vein hypothesis. You can achieve early symptom resolution. You can decrease the post-thrombotic syndrome severity. You may decrease post-thrombotic syndrome rates based on the current study, and you can improve the quality of life of these patients. I understand there is an argument. There is a dark side, high associated hospital costs, complications, and at the end of the day, you may not manage to decrease post-thrombotic syndrome. But isn't it like this in all procedures we are doing in vascular surgery? It's a matter of cost, risk, and benefit. And what if I told you that we can actually reduce complications? Then the benefit may actually be higher. So if I wrote the same editorial again today, I would probably convert it to the attractiveness of catheter-directed thrombectomy. And the landscape has been changing for years in other vascular beds. Myocardial infarction, we moved from systemic to catheter thrombolysis, and now they are doing thromboaspiration. Same thing with stroke, and this is what we are now seeing in DVT and pulmonary embolism. We are using more and more thromboaspiration to replace catheter thrombolysis. And of course, if you want to have optimal results, you need to choose the ideal candidate and do it right. So let's see our current algorithm for patient selection. We would only choose patients who have ilio-femoral or caval DVT. We are excluding patients with femoral popliteal DVTs. The ilio-femoral DVT needs to be ideally up to 2-3 weeks, but now with today's devices, we can actually take it up to 1 month. We can still remove the clot. We're going to assess their symptoms, and based on their symptoms, we're going to make a decision. If they have minimal or no symptoms, irrespective of the clot burden, we're doing nothing, anticoagulation only. If they have a threatened limb, phlegmagia, then you know you have to intervene. The difficult decision is for this group that has moderate to severe pain swelling. Well, for these patients, they will either get better, and you can go with anticoagulation only. They will get worse, and then you have to intervene. Ideally, you have to wait a couple of days. Some people actually say you have to wait up to 7 days to see how they feel. And it's not enough to just ask them, do you have pain while they are on their bed? You have to ask them to walk and see whether they feel heaviness. So for the young, mobile patient or the patient with a good life expectancy, these are the patients that you would consider intervening. They have persistent symptoms despite heparin drip or low molecular weight heparin. These are the patients you need to consider intervening. And for those who decide to intervene, you're going to assess their bleeding risk to decide what type of intervention you're going to offer. And I used to say, if you have low bleeding risk, you can consider catheter dripping or pharmacomechanical thrombectomy, moderate bleeding risk, aspiration thrombectomy, or pharmacomechanical thrombolysis, high bleeding risk, aspiration thrombectomy. But why not just do everyone with aspiration thrombectomy? We have so many new devices that you could consider aspiration thrombectomy for the majority of your patients. Let's discuss a little bit about the different techniques, because obviously there are strengths and weaknesses. Thrombolytic techniques using multi-site Foley catheters, they are generally very cheap, smaller devices. The good thing with the lytics is they can reach and clear the clot in remote beds. Venous branches, they will clear out the collaterals. They are vein wall and valve friendly. It's unlikely they will damage the vein wall or the valve. And the majority of the evidence we have right now is based on thrombolytic techniques. However, they are prolonged procedures, they prolong hospital stay, ICU stay, and you will still see major bleeding events. And there are contraindications. There are relative contraindications, and there are absolute contraindications. There's no need to go in detail through those. And the usual catheter we have been using is the Craig-McNamara from Medtronic or the Unifuse catheter from Hydrodynamics. You're going to use an infusion length that will cover the entire length of the clot. You're going to use 1 to 1.5 milligram per kilo of TPA per hour per catheter. The reperfusion is slow, and if you decide to stick with catheter thrombolysis only, you will most likely have to drip for at least 48 hours. Sometimes you have to drag it up to 3 days to get a final good angiographic result. And I don't think in today's practice we're doing this anymore. I'm using a lot of thrombolytics, but just as a jump start before I initiate my thrombectomy procedure. But in the earlier years, we have been doing this a lot. And on the other side, you have another thrombolytic technique with a similar concept of lytic infusion, but with the addition of ultrasound. The rationale behind this, and there are some in vitro studies indicating that acoustic pulse lysis can increase thrombus clearance by 50%. This is the ECOS device. It generates ultrasound that hopefully increases thrombus clearance, but this was not proven in clinical practice. The Bernutiful randomized trial in Switzerland, they had 48 patients with acute DVT. They used 24 patients, the ECOS catheter with the ultrasound activated, and another 24 patients that introduced the ECOS catheter without activating the ultrasound. And they found that the addition of ultrasound did not facilitate thrombus resolution. So my perspective is that this is probably a very expensive catheter to use with questionable outcome compared to a simple multi-site hole catheter. And the new addition, it's actually on trial right now in the US. That's the Bashic Endovascular catheter. And Interventional Cardiology and Temple University has developed it. I think the trial right now running in the US, it's for pulmonary embolism, but I had the opportunity to use it early on in DVT. It's a smart concept. You have multiple wires that can drip TPA, and they create multiple channels inside the clot. As you can see, this is a basket, and presumably they can speed up clot resolution, and you have to give less TPA. Well, this is to be seen. On the other side, we have the non-thrombolytic techniques, aspiration thrombectomy, minimal bleeding risk, no contraindications. You can achieve quick reperfusion, shorter ICU and hospital stay, but they come at a cost. Larger and more expensive devices. You can only do with the smaller ones, only luminal thrombectomy. You cannot get the clot off the wall. If they are too bulky, they can cause venous wall or valve injury. You will still get blood loss in a more controlled way because you're not only aspirating blood clot, you're also aspirating fresh blood. And there is limited, only industry-driven evidence. So we have multiple tools available, and I'm going to talk a little bit about each one of these devices. The Untitled Chapter, this is probably the catheter that everyone is familiar with. We have been using it for the past 10 years. This is the first device that I actually used back for the first time, 2011, 2012. It works in two modes. You start by infusing forcefully TPA inside the clot, the pulse spray mode. You wait for 30 minutes, and then you activate the thrombectomy mode when it aspirates the clot. And since we have been using the Untitled Chapter catheter, the concept of a single session thrombectomy came up. And with the Zelante catheter, that is a much bigger 8 French catheter compared to the 6 French catheter that we had early on, the Zelante results were much better. The most recent addition or evolution of the device is this Clot Hunter. The Clot Hunter connects on the back of the catheter. It spins the wire, allowing the catheter to go all around the world and all around the wall of the vein. So you can clear the clot from the wall instead of just doing luminal thrombectomy. The pharmacomechanical thrombolysis, though, has some disadvantages, and we recently published our experiences. If you use it very aggressively, you will get acute kidney injury. And we actually saw that in 22% of our patients that we used it, they developed acute kidney injury. You're going to see hematuria. You're going to see a bump in creatinine. Now, the majority of these patients will eventually get better. Why get into that? The predictors for getting this acute kidney injury were bilateral DVT, attempts to do single session pharmacomechanical thrombectomy, and female gender. So it makes sense when you have extensive DVT, particularly when it is bilateral, to jumpstart your case with thrombolytics for 6 hours. So you get a nice clear channel to come back later and finish it up with your angiojet device. Let's look at this case. 64-year-old female, acute left leg pain, numbness, unable to work, history of cancer. She's a functional patient. We thought this is a threatened limb phlegmasia. This is probably several years ago. I'm typically accessing the popliteal vein. You can see the clot in the femoral vein, clot in the common femoral vein in the external, and it seems it opens up at the common iliac vein and at the vena cava. You can see here the Zelante catheter going up and down, spraying the clot, and then initiating thrombectomy. It actually gave us a good result. You can see now the femoral vein being widely open, the iliac vein being open, but we uncovered an external iliac stenosis. This is where the cancer was in the radiation. We are doing intravascular ultrasound, confirming the stenosis, balloon dilatation, and back then we didn't have the novel Venous Stents. We used the wall stent, 16 by 90, post dilatation. Things look better. I still felt there was some disease at the common iliac vein. I did some more angiojet and eventually placed one more stent with a reasonably good final result. The patient had compartment syndrome. I had to release the compartments. Good final result. The patient was discharged a few days later. So more or less, this is how angiojet works. To be honest, I haven't been using it as much for the past 3-4 years as we have newer devices now available on the shelf. The AngioVac device, very large, very rigid, the early generation one, but very, very powerful. It involves an extracorporeal circuit. Practically, you are filtering all the blood out of the patient and you're bringing it up back to another venous cannula. You need very large sheets, 24, 22, 26 French sheets, but you can really remove big bulks of clot in the vena cava, in the iliac veins. We're also using it to remove clot from the superior vena cava or from the lungs. But the reality is it is very cumbersome to use because you need extracorporeal circulation. This is how the setup is. Some people are doing incisions to introduce the sheets. We don't do incisions, but we have to hold pressure afterwards for at least 30-40 minutes. This is a case coming through the IJ with the AngioVac catheter. You can see how it moves in to aspirate clot. The clot is kept in the filter. This was initiated by vena cava filter, which I then removed. But the device has now progressed. They came out a few years ago with a generation 3 of the AngioVac, and the most recent addition, which I think is going to be a big player in the field, as now they have a manual aspiration handle. This is the AlphaVac device. It recently got clearance and it's on trial right now in the US. It's amazing because you can go in through a 20 French sheath, and when the funnel opens up, you have a 46 French device that can aspirate the entire clot from the vena cava. And now you can do it with the ease of a handle. Another device, the Penumbra devices. We used back in 2016 or something like that, the Penumbra CAT 8 device. You need this aspiration device, and it connects to the Penumbra 8 French catheter. You saw how it works. This is an iliac vein thrombus. I'm using the CAT 8. I aspirated these pieces of clot and eventually placed a wall stent with a good final result. But now this device has also evolved. It's been almost a year and a half that Penumbra introduced the CAT 12 catheter, 12 French, and they have also introduced this intelligent so-called aspiration. It can detect blood clot and blood, so you reduce blood loss. The reality is with the CAT 8 device, we would lose 500, 600, 700 cc's of blood because of continuous aspiration. Now, whenever you are aspirating blood, the device will stop. And when you have to engage again back in clot, for the device to start again aspirating. This is the patient I did last year. You can see bilateral leg swelling. You can see there is a filter up in the vena cava, and the thrombus goes all the way up to the filter. Both iliacs are out, both femoral veins are out. We had him 48 hours on heparin. He didn't improve. So here we are in the operating room. I have the patient in the prone position. You can see 2 sheaths placed in the popliteal veins. You can see thrombus at the femoral veins, at the ilio-femoral, also higher up, and all the way up to the vena cava. You can see a lot of blood all the way up to the filter. So again, I felt that I might not be able to finish this in a single session. I introduced a unifuse catheter, 50 centimeter infusion length. I left it in. I think I probably did what we call the turbo boost technique. I forcefully infused a few milligrams of PPA, and then I just sat for 20 minutes. And you can see now that the channel has opened up, presumably making my life easier, and the catheter will now work better. So I have the 12 French sheath behind the knee. I'm introducing the CAT 12 catheter all the way up to the filter. And I start the aspiration. We have this separator wire that helps you unclog the catheter and keep aspirating. And this is the lightning component on and off to allow clot aspiration and prohibit blood loss. And I go down into the iliacs and then introduce it from the other side and do the other iliac and so on. And look at this now. I have a really good result. The blood now flows, but you can tell there is something left behind, both at the right iliac. I remind you the patient is on the prone position, and at the left. So whatever is left behind, I consider this as more chronic. I cannot remove it. I have to stent it. If I don't stent it, this will rethrombose. So I used IVUS, and I decided my landing zones. These are 2 Vichy stents placed in a kissing fashion. You can see how the flow, how good it is. This is the end result. However, if you notice, there was still clot left in the filter. So I go back in, I go through the IJ, I use the CAT 12 catheter again to clear the clot from the filter, and eventually I remove the filter out, as this was the nidus for the caval thrombosis to start with. And moving on to the Flowtriever device. We have been using this now for approximately 3 years. It involves the Flowtriever sheath. It started with 13. Now we have available a 16 French sheath. You can only go through the popliteal vein, and except for the sheath, there is this coring element and the collection bag. And I'll show you how this works. This is a case, this is an EVAR case we did, and in the postoperative period, the patient developed a bad DVT. You can see thrombus in the iliac vein, you can see thrombus up in the vena cava. So I introduced the Flowtriever device, and you can see here the coring element and the collection bag as I pull it down, going through the ilio-femoral segments, and that's the final result. No stent needed, good flow. And this is how the collection bag looks when you pull out the clot. Actually, it is very, very satisfying to see the clot coming out like this. Now, early on, I would also use the Flowtriever device. I have abandoned this. Flowtriever now, we only use it in the pulmonary embolism cases, but it's a way you can potentially remove thrombus if you have nothing else available. It comes in the 16, 20, or 24 French sheath. Again, I would go through the popliteal vein. This is the case where I had clot up in the filter. I removed it with a good final result. Now, there are multiple devices out there, multiple devices. I haven't used all of them, like the Jedi. I think it was recently bought from Abbott, Vetex catheter, the Aspirex recently bought from PD Medical, the Quick Clear Phillips, and a lot more probably in the pipeline. Bottom line, we should consider thrombolytic and non-thrombolytic techniques as complementary. Truth is that lytics will bail out an unsuccessful thrombectomy procedure. Thrombectomy will bail out an unsuccessful thrombolytic procedure. But it's not only about using a device. You have to know how to use it, and you have to know the rules of doing a successful thrombectomy. You have to target to clear thrombus by more than 90%. You need to be ready to stent. You need to predilate aggressively, use appropriately sized stents, land in healthy and proximal landing zones, use IVUS, extend to the IVC if you have to, or below the venous ligament if you have to. These are cases where I had to extend below the venous ligament. People who are only doing arteries cannot familiarize with this concept. The reality is fractures are very rare with these novel stents. We have been using wall stents for years. I can tell you, having used the novel venous stents now for the past 3-4 years, I'm not confident that the novel venous stents have a much better patency compared to the wall stent. It's just the wall stent is difficult to use and difficult to do the appropriate landing. But I think any of these stents can be okay in the right hands, following the rules. The Vici and the Venovo have actually been recalled now, approximately a year ago, because of some migration issues with the Vici and some mechanistic concerns for the Venovo. Of course, we need to understand that venous stenting is not reintervention-free. These patients need good follow-up. They will come back. The reason that the stents will fail will typically be poor anatomy, restenosis, problems with anticoagulation. But the reality is the majority of these cases will probably be a bad technique. So do these cases, but if you decide to do them, just do them right. Otherwise, don't do them at all. You have to follow the rules. You have to choose the right patients. You have to choose the right technique, clear thrombus, stent liberally, and follow them up closely. And with that, I want to thank you for your attention, and I would be happy to take any questions.
Efthymios, that was a fantastic lecture, and I did not realize there were so many different devices out there. A question I had was that you had mentioned that the algorithm that you are using at the University of Pittsburgh is that the patients that come in with acute Ilio-Femoral DVT, if you diagnose that you are putting them on oral anticoagulation first and then reevaluating at 48 hours. Is that correct? Is that for all patients that come through before you decide that they get catheter-directed thrombectomy?
Well, not all. The patients who have minimal symptoms,
Okay.
they're probably are ready to go. The patients who have severe symptoms, we're going to put them in the schedule the next day. The patients with symptoms are, so-and-so, not too good, not too bad. We wait 48 hours on a heparin drip or low molecular weight heparin, and we'll see how they will declare themselves within 48 hours.
Okay. So
I have a question, Peter.
Yep.
Is there any place for using any of these devices in the peripheral arterial system, just in the past, like in the old days, as we used simple catheter technique? Is it being used at all?
Actually, I'm an arterial surgeon first, and then I became a venous surgeon. So the knowledge we had in the arterial field, we then implemented it in the venous field. So we have been doing catheter thrombolysis in the arterial bed before we started doing venous thrombolysis. So we have been using the dripping techniques in the arteries, and then we took them into the veins. Regarding the thrombectomy devices, I think the angiojet device was first introduced as an arterial thrombectomy device. It's just the catheter was very small. So when we moved from the arteries into the veins, the angiojet catheter wasn't as successful. That's why a few years later, they introduced a bigger catheter that is dedicated for veins, and that's the angiojet Zelante. The Penumbra catheter, we are also using it in the arteries. The Penumbra CAT 8 is very successful to do an arterial thrombectomy for the femoral popliteal arteries. But it seems the Penumbra CAT 8 is now very small for the veins. That's why they came out with the Penumbra CAT 12, and now they're coming out with the Penumbra CAT 16. They keep going bigger because veins are much bigger, so you need a bigger device. Now, the Flowtriever device and the Flowtriever are only meant to be for veins.
Thank you.
Makis, I have two questions for you. So your last slide made the point about 90% clot resolution. Yet when I look at the clinical trials, the ATTRACT trial, the CAVIN trial, they had at least 50% of their patients who still had residual thrombus. So what techniques are you employing so that you don't have that residual thrombus there? So clearly, if you just do lytic therapy alone, you're always going to have residual thrombus. So is it the mechanical thrombectomy devices that are getting you to that 90% clot resolution?
So that's why sometimes you have to mix and match, Peter. And it actually comes with experience to try to remove as much as possible. And if you feel it cannot be removed, you just need to be ready to stent it. Whatever doesn't come out, you have to stent it. Otherwise, you're going to get rethrombosis. Truth is, with the newer devices, you can remove a lot of clot. You can probably remove all the clot. We are actually seeing that using the Flowtriever device, we don't need to stent as frequently. We used to say when we were using thrombolytic techniques, the stenting rate was 70 to 80% to get successful outcomes. Now, in the meetings that we are discussing our experiences with the Flowtriever device, the stenting rate is below 50%. We'll see. That's interesting point. We need more patients to tell that. But in any way, if I'm not happy with the amount of clot that has been removed, I will drip the patient overnight.
So my last question is, as you mentioned that we started on the arterial side and that we were doing lytic therapy, and most of these were inpatient procedures. And now we're slowly kind of moving these to a single setting outpatient procedure. So what tricks or advice do you have for those people who are considering doing this as a single session outpatient procedure? Like, what do you have to have in place other than good patient selection to kind of do this successfully?
So I would avoid bilateral DVTs. I would avoid extensive caval DVTs with an IVC filter in place. I would select kind of isolated ilio-femoral DVTs in good risk patients. I will have them first case in the morning, like a 7 a.m., 8 a.m. start. So if they have extensive DVT, I can drip them, get them out in the ward or in a monitored bed for 6 hours, drip TPA, and bring them up like last case of the day, 3-4 p.m. to finish them up. You could still try go single session with the angiojet, with the Flowtriever, but you need to be prepared that if it doesn't work, you're going to drip them for a few hours and bring them back at the end of the day. I think 99% of the cases, the patient will be able to go home by 6-7 p.m. Late afternoon.
Excellent. All right. Any other questions from the group?
Yeah, I was wondering, good morning. Where are we in terms of, or would you comment on infrainguinal disease? I know that it's a little taboo to just go after that. Are we going to take another shot at this with these new next generation devices and techniques?
Well, I think that's a big discussion. I don't know, Dr. Papas, have you been involved in the Mark Garcia study for using the ECOS catheter, dripping them overnight? And did you have any experience?
So I haven't been involved in the study, but I have used the catheter, and your earlier comment regarding the ECOS catheter was my experience as well. It didn't make a difference between that and just a simple multi-hole catheter. And I think what you said was right. It's an expensive multi-hole catheter. You know, they did have some data regarding pulmonary emboli, but that's not where most of the disease is. So I don't think the ECOS catheter makes much of a difference. And I'm, you know, with all the trials that we've done since, you know, when Mark Miser first did the original trials, looking at the femoral popliteal, all show the same thing. There's something unique about the femoral popliteal segment that rethrombosis. And the theory is that because it's a multi-valvular segment, it doesn't do well when you open it up. And plus, because you have the profunda, you get axial transformation very quickly, and the rethrombosis rate in the fem-pop is just high. So, and all the trials just keep seeing the same thing over and over and over. We haven't figured out how to make the fem-pop stay open.
Well, I totally agree with that. I think we still have a long way to go to identify the right patients for the ilio-femoral segment, right, and convince the medical community that we can do this in selected patients with ilio-femoral DVT. After we're done with this, we can start looking at femoral popliteal.
Yeah, but we still haven't showed that it decreases the incidence of PTS. I mean, I think Tony's data from the ATTRACT trial showing that the quality of life significantly improves is a big first step. And I think the other problem is that the endpoint of 2 years is just not long enough. Most of these patients don't develop severe PTS for 4, 5, 8 years. So even though the trials didn't show anything at 2 years, it doesn't mean that there's not going to be a longer term benefit. So I'm hopeful that the ATTRACT trial will follow these patients longer.
And my question, I'm going to take the opportunity and ask you, Dr. Papa, since you've done a lot of studies on anticoagulation.
Yeah.
I still haven't decided what's the optimal regimen. I will go with low molecular weight for 4 to 6 weeks for the patients that I'm going to stent. And then I will extend to 3 months, and then question mark.
So I
aspirin,
think
no aspirin. I know you have done a lot of work on using or not aspirin.
So I think the deflection point is whether or not it's a non-thrombotic or a thrombotic lesion. They clearly behave differently. The non-thrombotic lesions tend to be focal, and they really just don't need anticoagulation. There's no immediate, stent occlusion with the non-thrombotics. The post-thrombotics are different. And I agree with Bill Marston's analysis. Not all post-thrombotic patients are the same. A post-thrombotic occlusion that you recanalize behaves much, much differently than someone who's got a focal post-thrombotic lesion. And Bill's data shows that in the ones that are occluded that you recanalize, the anticoagulant you choose matters. And in his hands, he says that the low molecular weight heparins do better than, say, an oral factor 10A inhibitor. So all of the concern is on the post-thrombotic side. But I think the first step is we have to get physicians and interventionalists feeling comfortable with not anticoagulating non-thrombotics. And so that's why the paper that we just published focused mostly on the non-thrombotics. But the reality is, until you do a head-to-head trial and a clinical trial, people are still going to have fear and concern, even though the data is pretty clear that for the non-thrombotics, it doesn't matter. For the thrombotics, I think we need to do more work on figuring out which anticoagulant works, because clearly I think the 10As don't work as well as let's say, Lovenox does.
That's what I hear a lot. But then there is a big study from Switzerland. They said that they have equal outcomes. So it is confusing. What's the optimal anticoagulation regimen?
Well, listen, we threw out our experience, so let somebody prove me wrong.
Right. Right. Well, it's been a pleasure and a privilege, and I have to thank you so much for your kind invitation again.
So, Makis, thank you very much. You know, this year we've made a concerted effort to try to broaden the program and bring experts like yourself to kind of enhance the fellowship program and the lecture series. We're very grateful. We know it's 2:00 at your time in Athens, so thank you for your time. And listen, I'll see you next week in Orlando. Thank you very much, everyone.